So the highlights actually of this presentation, it will including actually the common liver lesions in the form of cystic and solid lesions. So it's the presentation actually will be including the hyperplastic benign solid lesions, liver cyst, and malignant liver lesions. سامعني كويس صح؟
ايوه كان كونتينيو يا مستر.
ممتاز.
Do you know the next slide?
It's okay. So this is actually the clinical approach for the any liver lesions actually. So the things that is very importantly that you're going to ask is the pain, and if there's any explained weight loss, anorexia, diarrhea, and dysentery, which is definitely is related mainly to the amoebic dysentery and amoebic abscess and biogenic abscess, relation to the contraceptive pills, androgens, which is related mainly to the hepatocellular adenomas, jaundice fever, history of malignancy in case of the metastasis, and history of hepatitis. You will look definitely for the primary tumors, for example, like GI tumors or signs of stigmata of liver cirrhosis, which is mainly related to hepatocellular carcinoma at the end, if there is patient having a palpable liver, and confirm these findings actually with the investigations in the form of ultrasound, a CT scan, which is triphasic CT scan. The triphasic CT scan definitely is, if everybody doesn't know exactly what is it, it's a 3-phase of the CT scan in which getting the arterial phase, portovenous, and delayed phase in relation to the injection of the contrast. And the arterial phase most of the time is getting actually the cuts between the 30 to 45 seconds. And the portovenous phase actually giving the cuts actually between 60 to 75 seconds. And the delayed form, there's 2 protocols actually. One of the protocols it will be done actually between 3 to 5 minutes, and the other one between 4 to 6 minutes. So I was speaking initially actually about the benign liver lesions. So it's a heterogeneous group actually of liver lesions frequently found incidentally. Why? Because we usually at time being we are using the radiological investigation so frequently actually. So most of the time you can just easily getting actually a liver lesions, and you start actually to ask yourself, and the patient might start to ask about what is it and what is the kind of the proper treatment that it should be offered for him. So most of the time it's a benign course. Some of them are having a greater relevance more than the others in relation to the pre-malignant condition, or if it's having actually a special way of the treatment. So there's 4 more common solid benign liver lesions that will need to be discussed, which is the hepatic hemangiomas, focal nodular hyperplasia, hepatocellular adenoma, and the patient with multiple lesions. So let us start with the hemangioma as a first category. So what is hemangioma? It's the most common primary benign tumors that present with the radiological investigation, that present with about 5% from the cases. In the autopsies, one of the autopsy series, actually, they found the hemangiomas in about 20% actually from these cases. It's most commonly present actually between the 3rd and the 5th decade of life, and male having more hemangiomas rather than the females, but it can occur definitely in all age groups. Sometimes having some rarely a clinical significance because it's a small and solitary, but in some series actually it could present actually reaching to up to 20 centimeter in diameter. And most of the patients, it's asymptomatic, but large ones definitely could give some symptoms in the form of pressure on the glycine capsule, giving some pain. And in some large tumors, even it's leading to coagulation consumptions and forming anticoagulopathy and leading to Kasselbach-Mittelschmerz syndrome. So how this hemangioma can be diagnosed with the radiological investigation? It's most of the time with the ultrasound. It's homogeneous and lobulated and hyperechoic mass. Okay. And the CT scan, if you could see here, it have very special character. The characteristics actually in the CT scan, it's not showing actually during the arterial phase. It's getting a nodular enhancement to our centripetal enhancement with the delayed phase. Okay. So as you can see it here, I'm sorry, the mouse is not working. Okay, fine. السلام عليكم، سامعيني يا جماعة؟
واصل واصل سامعينك يا مستر إبراهيم.
Okay. Now if we could see actually here the MRI character, it's very obviously during this, with this 5 pictures, the hemangioma is strongly hypertense actually with the T2 and hypointense actually with the T1. Okay, fine. In the contrast CT scan in the third slide, you could see the cotton wool-like appearance or centripetal intensity that present actually on the periphery of this lesion, which is suggesting hemangioma, and I don't think it will need any further investigation more than this. So what we're doing for it, definitely it's basically, the diagnosis is mainly related actually to radiological investigation. Rather, we don't advise actually for any percutaneous biopsy. So why? Because it could bleed actually easily. Resection is rarely necessary. In cases of the symptomatic hemangiomas, we can actually offering the patient surgical intervention in the form of resection or even inoculation. So focal nodular hyperplasia, this is the second most common clinical, most common benign lesion that's present in the liver, and it's most of the time it's in a female gender, and the average presentation actually between 35 to 50 years in age. The clinical characteristics of the focal nodular hyperplasia is the most commonly it's a solitary and less than 5 centimeters in size. But in some cases actually could present as a multiple in between 20 to 30 cases actually. And if you go actually to what is this focal nodular hyperplasia, it's a hyperplastic hepatocellular lesions in relation to congenital AV malformation. Okay, the size stay most of the time stable for years, and in most of the cases it's mostly just only asymptomatic and doesn't need any kind of intervention. So how it's actually present with the CT scan, how you can diagnose this, it's homogeneously hyper intense tumor that present actually with the CT scan. Okay, so the 5 criteria actually for the diagnosis, just remember it again. The lesion is homogeneous and sometimes having a central scar. There is a slight difference from the adjacent liver tissue and the arterial phase. So in the arterial phase, it's homogeneous and the same actually density of the IVC. In the portovenous phase, it's become hyperintense. Okay, this is the characteristic for it. And most of the time, it's having a central scar, especially with the MRI. It lacking capsules. There's no capsule around it, which is differentiating it from the hepatocellular adenomas. Okay. So it's safely to be observed with no evidence actually for malignant potential for this disease. I have a nice algorithm actually about how to manage actually this patient. If you're suspecting a focal nodular hyperplasia, we'll do CT scan with triphasic CT. And if the diagnosis is very clear with this radiological modality, just to follow up the patient, that the patient doesn't need any kind of an intervention. So if you are, the diagnosis is still in question with the CT scan and the MR. So what we're going to do, if the size is less than 3 centimeters, you will do a contrast enhanced ultrasound, which is by using the microbubbles. Microbubbles will get absorbed actually with the highly rich cover cells that present with the focal nodular hyperplasia, so it gives the diagnosis easily. But if it's more than 3 centimeters and is still doubting actually the diagnosis, you can just biopsy it. If it's confirmed FNH, just get the patient for follow-up and that's it. So next is hepatic adenoma. So what is this hepatic adenoma? Actually, it's the epidemiology is present a little bit as rare disease, not very commonly. And it's about less than the focal nodular hyperplasia presentation. And most commonly it's present in, definitely in women, and 10 times to 1 with the females to male. It's most of the time present within the third and fourth decade of life. Uh, it's usually round and well circumscribed, and most of the time it's solitary. Uh, Mostly the size actually between 5 to 15 centimeter, and always it's having a pseudocapsules. So potentiality to sex hormones, you can always seeing this hepatocellular adenomas with those female patients on oral contraceptive pills for very long time. And even it's can be seen actually with the male patients that presenting on the anabolic steroids for very long time, like in the bodybuilder. Some diseases like glycogen storage disorders actually having high predisposition for the hepatocellular adenomas. In the recent there is a recent increase actually in the prevalence associated with rising obesity and metabolic syndrome in obese patients. There's a significant risk of hemorrhage, especially and malignant transformation, especially if the size of this tumor is more than 5 centimeters. So how it looks actually on the CT scan. So in the CT scan, if you could see this CT now, remember, and it's giving some characteristic of the hepatocellular carcinoma in the form of what? It having rapid uptake with the arterial phase, and there is a storm, and there is rapid washout actually with the portovenous phase. The thing that is very importantly, actually, it have a capsule that present, which is differentiating it actually from the focal nodular hyperplasia. So, in regard of the epidemiology of this disease, is mostly, as I mentioned before, I'm sorry, this is double slide. So, what is the treatment actually for the hepatic adenoma? Stop the oral contraceptive pills and stop the anabolic steroids. So, this is very nice actually algorithm for the treatment of the hepatocellular adenoma. So, we will do a CT scan or a contrast enhanced MR. In case of the females, irrespective of the tumor size, just adjust the lifestyle and follow this patient up after 6 months. Uh, if the size of the tumor didn't increase or that the size is stable or less than 5 centimeters, just you will put the patient on follow-up after 1 year. But in case of the male patients with hepatocellular adenoma, the risk of malignancy is much higher, so we'll go straight forward for the resection. Or those cases, female patients who having actually this tumor that is more than 5 centimeter and the risk of malignancy would be more than 10%. So it's much better actually to do a resection for them than to put them actually under surveillance. So this actually table is differentiating, getting the main characteristics between the three uh, hyperplastic solid tumors of the liver. So if you could see just the most important thing is that there is a centripetal enhancement that present in the hemangioma, as I told you, in the delayed phase. There is a presence of central scar that present in the focal nodular hyperplasia. And finally, actually, the rupture, it's very common with the hepatocellular adenoma, especially for those patients on the oral contraceptive pills for a very long time, or the size of the test tumor is more than 5 centimeters. So now we just will go for the next partition actually of this presentation, which is the liver cysts. So we have solitary cyst, polycystic disease, traumatic cyst, cyst adenoma or MCN, or hydatid parasitic cysts. So a regard of the liver cyst is frequently identified incidentally, and in one of the series it's actually present with about 5% actually from all the scans, and most commonly is congenital. And usually it's solitary, but it could be a polycystic. But if it's polycystic, you have to make sure that it's not a part of the polycystic disease that related to the digestive system, mainly for the kidneys and the other area of the digestive system. So it's primarily cystic component, just to have to differentiate it from cyst adenoma or cyst adenocarcinoma. So how this solitary cyst actually present with the radiological investigation? The first with the ultrasound is anechoic or hyperechoic, well-defined lesion. Okay, on the CT scan, actually with the IV contrast, you you will find a simple cyst in the form of having a low, very low house field units. It's well circumscribed and hypodense. This is actually the MRI and the T2, so it's very well circumscribed without any kind of mutations and the clear cyst. So how we are managing this cyst, most of the time just only it's asymptomatic and we need no kind of treatment. If those cysts are large enough and giving symptoms, so we might need to rule out malignancy or especially, or at least the MCN, mucinous cyst neoplasm or cyst adenomas. Okay. Many methods to treat the simple cyst. The most effective is the laparoscopic deroofing. So briefly about the polycystic liver disease, we have two forms. The childhood polycystic liver disease, which is mostly it's autosomal recessive disease affecting mostly the liver and the kidneys. It could give some fibrosis and portal hypertension for the child. Despite it, most of the time it's present with the adulthood for the childhood polycystic disease. Uh, the adulthood or adult polycystic liver disease, which is a different one, which is mostly affecting the gene type 2 from the polycystic liver disease gene, as it's inherited as autosomal dominant, and the liver is macroscopically diffusely cystic. This disease is mostly progressive and is increasing with the age. And for example, if there is 20% actually from the liver is affected with this cyst by in the second decade, maybe about 70% could be affected with the age of 70. So what we are doing for them, you have actually to carefully select this patient will need kind of the treatment. Why? Because most of the time we don't have offer this patient any kind of treatment unless there is some symptoms. So what the option that we can give it to the patients in the form of percutaneous aspiration, but the recurrence is 100%. So the other way of treatment by the surgical and roofing, we preferring actually the laparoscopic approach at the time being. So traumatic cyst, this is actually as a sequelae of liver trauma, either blunt or penetrating trauma. So it's leading to accumulation of some blood, bile, and necrotic liver tissues that develops. At the end, it's lacking actually the cuboidal layer that present with the true cyst. So it's not actual cyst; it's a pseudocyst. Most of the time, it's a sequelae actually of the arterial infarction and might lead to biliary stricture secondary to the bile duct transection and periductal inflammation. So cystadenoma or MCN. Okay. Uh, it's mostly present actually in less than 5% from the whole cystic lesions actually of the liver. It's most commonly actually in the females, and grossly the tumor are usually large and mostly in the right lobe and sometimes could be multilocular. So contrast enhancement of the cysta is very important to differentiate this cystic lesions from the true cyst or from the other types of cyst. So microscopically, it have a diagnostic feature. It's because it's multinucleated lesion lined by benign or malignant mucin producing cells. And you will see some polypoid papillary projections into this cyst. So the feature suggesting of neoplastic cyst on the ultrasound and the CT scan, the papillary projection and the irregularity actually in the cell and the cyst wall. And you could see some nodular actually presentation that patients most of the time you could see some nodularity that present actually in the periphery of the cyst. So this is raising the suspicion this cyst is different and it's not a true cyst. So it's obviously here you could see the segmentations and there is some area of nodularity that present anteriorly. So just remember cystadenoma, it's a pre-malignant condition and this way of the treatment mostly need to be different from the other cystic lesions that present. So it's very importantly to differentiate it from the hydatid cyst, and surgical liver resection is one of the options of the treatment. Partial resection and aspiration most of the time is not ideal and going actually with recurrence. So let's speak a little bit actually about the hydatid parasitic cyst. So the infection of the hydatid cyst actually is presented by the Echinococcus granulosus parasitic infection. Most of the time it's asymptomatic disease and may remain so until they reach actually to the large size. So the hydatid cysts are found frequently and incidentally could present actually in about 82% from the during the investigation for other reasons. So it's good infected and present like abscess. So in general, we have since long time during my residency, I was thinking all the time that we have only one type of the hydatid cyst, but actually we have five types, and not all of them will necessitate the treatment. So if you go actually about in this CT scan, you will find five different types. The first one is the unilateral anechoic cystic lesion, which is the CA1. So you will see a double layers actually that present and formed from the true endocyst of the hydatid itself, and the ectocyst, which is the host reaction from the adjacent tissue. The second one type is making a rosette-like and or the honeycomb appearance, and mostly this is as well is a very active disease and this will need a treatment. The third type is equivocal and most of the time is not really active. If there is a cyst that with detaching, giving the lollipop appearance, actually, if you see it here in CA3A, or the water lily sign, and in the third B types, actually, you will find the daughter cyst that present actually within the cyst. So this is two types are transitional about the activity of this disease. The fourth and the fifth types are inactive, and most of the time they don't need actually to some sort of resection, in which the cyst you will find it heterogeneous and hypoechoic. That's mostly the parasite is almost dead actually in this stage. And the fifth types you will find the calcification on the wall, so sanguineous calcification that's present actually on the wall of the cyst. That means the cyst is not active. So this is how it looks in general. That can the incident that present. So the treatment of the hepatic cyst require control of the cyst if we have it, if it's active, in the form of starting with the antihelmintic medications actually for 2 weeks in the form of albendazole or bendazole, and then you will start to attempt actually the way of the treatment. The way of the treatment could be percutaneously in the famous spear technique that puncture, uh, inject of solicidal material and re-aspirate aspirate and then re-inject again. So the other way is just doing a laparoscopic or open resection or either uh, inoculation of this cyst, but taking care actually most of the time not to let any of the highly anaphylactic fluid to spill to the patient peritoneum. So in speaking actually about the abscess, abscess actually it's present with the different routes actually to the liver. The most common cause it could be biogenic, fungal, or parasitic. The etiology is mostly in immunocompromised. The most common cause of biogenic abscess is cryptogenic without any obvious cause. Biliary infection in the form of the ascending cholangitis or the could be one of the reasons. GI infections and leading to portal vein bulimia and in relation to appendicitis or complicated appendicitis or diverticulitis, or it could be a post-operative, for example, in post-transplantation. And finally, parasitic abscess like amoebic or echinococcal, superimposed secondary infection of both. So this is the routes actually how the infection could reach to the liver. So through the hepatic artery in the form of bacteremia, portal vein from the GI, and finally from the bile duct with direct extension through the through the biliary system. So this is now actually the picture that you can easily diagnose the abscess on the CT scan. You will see there is a multiple hypodense fluid collection that present. Hello? Hypodense fluid collection that present in one lobe, which most of the time in the right lobe actually of the liver, or in the sometimes you will find the multiple tiny small abscesses that present on the whole the lobe of the liver. If you can see on the left side, there is a well circumscribed fluid collection that present within the liver and having a less liver edema in the comparison with the pyogenic liver abscess. So how we're going actually to treat it? So if the abscess comes and rupture, that means we need surgical drain. If not, does this abscess is iatrogenic? If yes, okay, that means it will need to be drained percutaneously. If it's recur again, you can do again percutaneous drainage. This definitely beside the antibiotic administration. So if this abscess is from the start is less than 3 centimeters, that means the success rate with the complete resolution with the antibiotic it will be high. So just you don't need to drain it. So we'll go quickly with the common malignant liver lesions. We have hepatocellular carcinoma, intrahepatic cholangiocarcinoma, secondary liver metastasis, and liver lymphoma. So the HCC, it's increasing actually with the incidence currently. So increasing in incidence, the prognosis improving with the screening and the early diagnosis that presented time being that there is some screening that active screening programs that is running actually in countries like in Asia that having much of the hepatocellular disease. Not most of the time you will need actually to biopsy it. If you have a good output from the contrast based image in the form of this triphasic CT scan or the MR actually with the gadolinium study or the liver protocols, you can just give you a lot actually from the information without the need actually of biopsying actually the tumor. So there's very important thing that the multidisciplinary team, this day is the multidisciplinary team time in whatever the type actually of malignancy, you will get the best involved healthcare providers in the form of radiologists, in the form of the oncologists, and in the form of the hepatologists even, to give you the input about the proper treatment actually of this patient. So, statistics, it is the fifth most common cancer worldwide. Excuse me, Dr. Muhammad?
Can continue, Mr.
Okay, fine. So it's the fifth most common cancer worldwide. It's approximately about 500 cases per year. Definitely, its relation to the hepatitis B and C is very importantly increasing with those countries which is endemic with this kind of disease. Alcoholism is one of the causes. Hepatitis B and C as hematochromatoses, porphyria, Wilson disease. Alpha toxin is one of the risk factor actually for hepatocellular carcinoma. So how we can diagnose the HCC? The old criteria, we will need the alpha fetoprotein that's more than 400. In the context actually with the liver lesion accepted as a diagnostic. But now, no. With the new criteria, we need the arterial enhancing lesion with early washout in the MR or the CT scan with a size at least of 2 centimeters in the two modalities of them, or two modalities plus the increasing of the alpha fetoprotein. So if the biopsy done usefully, we don't actually advise the biopsying the HCC. There is multiple actually reasons for this. The high actually specificity and sensitivity of the radiological investigation, beside the possibility of the bleeding with the HCC, and finally with the lesser actually risk the seedling on the tract actually of the biopsy itself. So hepatocellular carcinoma, how it's present actually with the CT scan. It's hypervascular in the arterial phase and homogeneous in less than 3 centimeters. Just remember, it having very unique characteristics. If you could see here, within the arterial phase, it have taking a rapid uptake, okay? And there is a rapid washout in the venous phase, and there is enhancement that present actually within the capsule in the delayed phase. It's multilobulated. Okay, you could find an area of the necrosis with the SCC with the CT scan. I think it's very obvious. So there is some variant actually of the hepatocellular carcinoma, which is called the fibrolamellar, that present in the younger age group, and most of the time patient having no cirrhosis, with mostly more than 70% with a normal alpha fetoprotein uh, value. So it resembles actually the hepatocellular carcinoma in the CT scan, in form of that it's having arterial enhancement and rapid washout with the portovenous phase, and there is a capsule that it's encapsulated, and this capsule is enhancing actually with the delayed phase. So briefly, the principles of the treatment. I'm about actually, inshallah, to finish the presentation. So we have multiple actually multiple systems actually for the making actually the characteristic, differentiating actually the proper treatment actually of the patients with the HCC. One of the excellent protocols is the Barcelona. It's including clinical and the patient stage plus the patient functionality, okay, and the tailoring the way of the treatment. So it's classified it into 5 categories. The first one is very early. That means the patient physically is excellent with a child score 1 and in less than 2 centimeter tumor. Early stage between the same function plus there is 1 to 3 lesions that less than 3 centimeter. Stage 3, the intermediate, it's multinodular, okay, but the child A, it's still child A and good functional status. So this definitely the 3 categories having actually a good outcome with the different types, modalities of the treatments. So we have the advanced stage. If there is a vascular invasion or there is M1 metastasis or there is actually a positive lymph nodes. Terminal, regardless, if the patient general condition is very bad, like patient having a child score of C, and patient even physical activity or echo classification on the 2, that patient even cannot go actually to dealing the necessity of daily style or life needs by himself. So briefly, actually, with the first 3 categories that I mentioned, we are favoring actually the surgical resection or the ablation if it's very early disease. The ablation present actually, we can do it with the radiofrequency ablation with some criteria that I will go to get to it later on. And in the early stage, if the patient have a portal hypertension, we can do a liver resection. If not, we can go straight forward for the resection. In the intermediate stage, we can do a chemoembolization for this patient. Effective treatment will be with definitely is going to affect the impact. If you could resect, you can ablate well the patient having the survival of more than 5 years, and the other actually Barcelona advanced scoring, mostly the liver survival, the survivor actually will drop so dramatically. In the very advanced or terminal case, the survival will be not more than 3 months. So the surgical resection, when you are going actually to attempt the surgical resection for the HCC, there is 2 questions which is very importantly. The first one, I will get the first one, which is the resectability, how much you are going to resect and how much you're going to leave. Okay, so there is a rule in the resection, you should not take more than leaving the functional reserve of the liver after the resection shouldn't be less than 20% with the normal liver, not less than 30% with the statotic liver, not less than 40% with the cirrhotic liver. Why? Because this patient will end with the decompensation and liver failure. So the second question, shall we do a resection or transplant? So the transplant cures the cirrhosis and can definitely remove the occult synchronous lesions. And the main issue and main cause actually of this, the liver transplantation is the availability of the transplant. Okay, not most of the time. Most of the patients will be on a waiting list for a while and not find actually the liver easily. So we can bridge these patients if there is any possibility of coming soon liver transplant, you can bridge them actually with the TACE or the radiofrequency ablation for this tumor. So definitely the criteria of the liver transplant, there is a rules for it, which is the Milan criteria, that the single lesion should be not more than 5 centimeters, and it must be not more than 3 lesions, each not more than 3 centimeters, no vascular invasion, and definitely no extrahepatic disease. For the extended criteria for these lesions, that's less than 6.5, and even 3 lesions, again, but not more than 4.5 in size, and there is no vascular invasion and there is no metastasis actually outside the. So the ablation techniques, we have 3 known ablations therapies. The first one is the radiofrequency ablation. The radiofrequency ablations, it's dissipate a lot of heat actually within the tumor, but the maximum here is written 3.5%. What I know is up to 5 centimeter actually in size could be ablated, but not be more than 3 lesions. There is some areas which is difficult to be accessible percutaneously in the liver, like the dome that's near on the border or very near actually from the blood vessels. You can be done with the laparoscopy assisted. The chemoembolization, that if it's larger but isolated to the liver, uh, the trial that showed the benefit of this selected intermediate stage, no advanced liver disease, no vascular invasion, and no shunting, and no extrahepatic disease. The largest tumor should not be more than 7 centimeters in size. So this is the radiofrequency ablation. This is the needle that we are using for the ablating the liver tumors. And some using ethanol, but it's definitely less superior than the radiofrequency ablation. This is the chemoembolization. You could see here the shunting and the hypervascular tumor, and this is after the embolization. In the advanced disease, the SHARP trial actually showed that a grade of the survival benefit from the sorafenib as a first phase 3 showing survival benefit chemotherapy agent, cytotoxic agent. So to speak briefly about the cholangiocarcinoma, the tumor arises actually from the bile duct epithelium, and 95% is adenocarcinoma. It could be associated actually with the primary sclerosing cholangitis, choledochal cyst, drug exposure, or congenital hepatic fibrosis, and viral hepatitis. So we have mainly 3 main categories, could be the tamamdis, which are the intrahepatic cholangiocarcinoma, highlight that means the cholestatic tumor, and finally extrahepatic cholangiocarcinoma, which is out actually from this presentation. The intrahepatic types, we have 3 main categories. The first one is the mass-forming intrahepatic cholangiocarcinoma, or could present with the preductal infiltrating cholangiocarcinoma that pressing and compressing the biliary radicals, and it goes actually like a saddles on the bifurcations of the branches of the biliary system, intrahepatic biliary system. Finally, the intraductal cholangiocarcinoma. So if you could see here, this is in the CT scan, the cholangiocarcinoma. It's usually not a hypervascular disease, and that's against the hepatocellular carcinoma. It's not actually getting an enhancement on the arterial phase. It shows mostly on the delayed phase. So it's lack of capsule, and most of the time it's associated with the capsular retraction, and this is mostly for the mass-forming intrahepatic cholangiocarcinoma. So it is, again, it's not giving enhancement on the arterial phase, it's enhancing on the delayed phase, and most of the time it's associated with capsular retraction, liver capsule retraction. So this is the preductal infiltrative cholangiocarcinoma. It's leading to some sort of obstruction actually of one of the branches of the biliary system, mostly the sectorals. So the most important thing, again, beside that, it's enhancing only in the delayed phase. Most of the time is giving dilatation in the proximal biliary radicals plus atrophy of the lobes. So this is how it looks. So if you can see in the exam, there is a mass within the liver and there is a biliary dilatation, just make sure that it's a cholangiocarcinoma more than anything else. So just skip this. I want to speak actually about liver lymphoma because it's one of the diseases that you could actually see it. It's hypoechoic. I'm sorry, it's hypodense tumors, and as well, you should always looking for the lymph node that presents somewhere else actually. So complete the CT scan, including the chest, abdomen, and pelvis, and see the lymph nodes that present anywhere actually, because will help you actually in the reaching with the diagnosis. Treatments to purely medical treatment actually, and most of the time, mostly it's non-Hodgkin lymphomas, non-Hodgkin disease. So quickly about the liver metastasis, it is the most common secondary liver lesions, and there is a detailed history of known malignancy is very crucial. You have to get to know exactly if the patient have any other primary disease. Once you will see these liver lesions that incidentally found on the CT scan, just you can match it actually with the primary tumor. Definitely the treatment mostly will get tailored actually about the nature of the disease. Tumor markers is one of the workup during should be done within the workup, but definitely it will not be used for the diagnosis. So uh, the metastasis, most of the time it's hypodense lesions within the arterial face, and the CT scan could sometimes missing these lesions if it's in size is less than 15 millimeter in size. So if it's less than 15 millimeter in size and it's only one incidental lesion that hypodense with the arterial face, so what comes of your mind that is mostly benign. So the risk of malignancy is about 5%. So if it's between 2 to 4 lesions that hypodense actually within the arterial face, so the possibility of malignancy will raise to about 17%. But more than this, you have to know that the possibility of malignancy is about 74%, and you have to check for the primary cause. So most of the time, the liver metastases are hypodense, but it could sometimes present to be a hyperdense in the form of, we call it the MRCT PET. So MR for the melanoma, renal cell carcinoma, CT for choriocarcinoma and thyroid cancer, and PET for neuroendocrine tumor. So this amidectomy, and thank you very much actually.
شكرا جزيلا يا مستر على المحاضرة الغيمة. for the sake of time ممكن نمشي للجزء الثاني من المحاضرة ونخلي الأسئلة في النهاية.
أيوة.
تمام.
It's very long one.
It's okay, it's okay, it's okay.
طيب, just now go out.
How are we going to this? That's good.
Just only one thing. طبعا يا دكتور محمد.
You're welcome. Welcome, Mr.
طبعا Mr. Amer Duri, he is a senior lecturer actually in Leeds University, and he's a senior consultant of hepatobiliary with pancreatic fellowship. So the main issue is only one thing that طبعا احنا asaf we are new actually for the Zoom. We have a screen that covering half actually of the screen. عشان كده انا حتى لما كنا بنقرا معنا كنا عارفين نقرا الكلام نصه يعني. Okay.
No, you are welcome. You are welcome, Mr.
I just wanted to give us 1 minute.
Okay.
Is it better here?
So yeah, it's much better.
Okay. Assalamu alaikum. My name is Amer, and I'm going to just briefly talk about incidental lesion in the pancreas. So, if anyone, if I say something which is not clear, please stop me and ask what I mean. So, nowadays we do scans for unrelated symptoms, and many patients, they will have lesion in the pancreas. So for the sake of this presentation, I use some images from website called the Radiology Assistant. It is from Netherlands. They have nice images. So all the images I'm going to show, it is nearly derived from this website, and this is just to declare from where I got the images. So when we do CT scan for any reason of symptoms in the abdomen, we may have a surprise there is a lesion into the pancreas. The most important thing really to recognize or to differentiate is this lesion simple pseudocyst or a lesion which is benign, you don't need to worry about it, doesn't need treatment because the patient doesn't have symptoms, or actually it is a lesion which is cancer, malignant tumor, or actually it is a benign tumor which has a tendency to transform in the future to malignant. So for this reason, it is very important to try to differentiate the incidental finding we have into the pancreas. Is it something we need to worry about? Is it malignant or going to be malignant in the future, or it is just simply a benign lesion, and because it's asymptomatic, we don't need to worry about it? And it is the image I'm going to show you. I'm not going to go in detail into it because it is not our job. It is the job of the radiologist to answer the questions we have. But briefly, you can see on the screen. Can you see the screen? Can you see the presentation on the screen?
Yes, yes.
Yeah. So on the screen we have two images. One image it is on the right side of the screen with the a blue arrow. This showed a cystic lesion, but you can see the wall of the cystic lesion is irregular wall, and it has nodules. And this is a lesion which is we worry about. It's a suspicious lesion. Most likely this is a tumor, could be benign or could be malignant tumor. While on the other side of the screen we can see a cystic lesion, which is there is a line into the middle of the lesion to measure the size of the lesion. This lesion, the wall of the lesion is thin wall. You cannot see nodules. There is no septation, so it is more likely to be a benign lesion. It is not as simple as that, but this is the main criteria we're going to look at. Now, let us just briefly discuss the lesions which is benign, doesn't need treatment, and has no malignant potential, and then we come to the lesions which has malignant potential. One of the common lesions could be seen in the pancreas, especially in ladies above age of 60s. It is what we call it serous cyst adenoma. And serous cyst adenoma has a characteristic feature. Here on the screen, we see the same image, but one of them is a bit magnified than the other. You can see there is cystic lesion into the head of pancreas, which is I don't know how to point there, but you can see there is cystic lesion, and the cystic lesion has septation and has appearance which we call it honeycombs appearance, which is basically it is a cluster, a large group of small cystic lesions, and that is what we call a cyst adenoma. This is 90% of cyst adenoma is what they call it has an appearance of honeycombs appearance on radiology. These lesions sometimes has a central calcification, as we see in this CT scan. In this CT scan, we see there is a lesion which is multilocular, a lesion which has multiple cystic lesion, but the center of it has calcification, and this red arrow is showing where is the calcification. And this is a feature of cyst adenoma. These lesions are benign. They do not transform to malignancy, and they do not contain mucus. They contain serous fluid. That's why they call it a serous cystadenoma. I think there is 27 case report that there is transformation to malignancy, but they estimate the risk of such lesion to develop malignancy at any stage is less than 1 in 10,000. So in reality, if I have a patient who has this feature, which is our radiologist is confident this is a serous adenoma, then patient doesn't need surgery. However, serous adenoma can cause mass effect. So if it's increased in size, it may cause pressure on the duodenum and cause a gastric outlet obstruction. At that time, the patient will need treatment. But most of the cases, the patient will not need any treatment because it is very unlikely to have malignant transformation. This is another picture of serous adenoma, and you can see the multiple cystic lesion honeycomb appearance. Another lesion, which is actually this lesion is a tumor. It is not a simple lesion, and this lesion needs treatment. This lesion, what we call it, the mucin cystic neoplasm, mucin secreting cystic neoplasm, and most of the surgeons they call it MCN. This lesion usually happen into the body and tail of pancreas, and usually happen in ladies youngish in their age, usually either late 20s, 30s, or beginning of 40-year-old. Is unlikely to see it in someone who is 70-year-old. This lesion has characteristic that the stroma of the lesion is similar to the ovarian stroma. They do not know why, and interestingly, it is much more common in ladies than in gentlemen. So if you have a gentleman and you have this lesion there, you think it is MCN, mucin secreting cystic neoplasm, you have to question your diagnosis. It could happen in men, but it is much more common in female. These lesions could have a peripheral in the wall of the lesion. You could have calcification, as shown in this image. The red arrow showed the calcification of the cystic lesion. The MCN contain mucus from the name. It is a mucin secreting cystic neoplasm, and it has malignant potential. If you leave it, it could develop malignancy. So all the data we know, it's coming from the resected segments, resected specimen. So the patient who had resection for this lesion, in the beginning, 10, 15 years, the publication tend to quote about up to 30% presence of high-grade dysplasia or invasive carcinoma in these lesions. But in reality, recently, when the number of cases which resected is larger and can give better understanding of the malignant potential, they guess it's about 10%. So if you resect 10 MCN, you expect one of them will have invasive cancer or have high-grade dysplasia, which is carcinoma in situ. So basically, this lesion, which is the MCN, it is a tumor. It is a benign tumor with malignant transformation potential, and it should be resected if the patient is fit. And usually it's happening in middle-aged ladies. So usually they are fit for resection, and we should resect them. It could happen in the head of pancreas, but it is more likely to happen into the body and the tail of pancreas, as in this image. Another type of tumor which could happen in young ladies, and the best way to remember them is if we started with the first lesion, which is the serous adenoma, happen in elderly women. Then the MCN happen in middle-aged women, and this type of tumor, which called solid pseudopapillary tumor, this usually happen in young ladies, something around their 20s. So there is young lady in her 20 comes with incidental or vague abdominal pain, and we do image and we found lesion. This lesion is more likely to be solid pseudopapillary tumor than it is cirrhosis adenoma. This tumor has malignant transformation, and the characteristic of this tumor on images, as we said before in the first slide, we had that when there is irregularity of the wall, when there is no nodules inside the cystic lesion, then we worry about the lesion being tumor actually, not a simple cyst. And you can see here in this lesion where the red arrow is, you can see that there is the wall of the cyst contain irregularity. There is nodules, and it is in reality it is mixed tumor, cystic part and solid part. And this tumor, when you remove them, even if they have malignant transformation, they have a fantastic outcome. This tumor, the 5-year survival reach up to 98%. So the pseudopapillary tumors, they have very good outcome. That's why if we diagnose them, we are very aggressive in treating them because they are relatively curable disease. They are completely different from the ductal adenocarcinoma of the pancreas. Another lesion which could present incidentally, it is neuroendocrine tumor. And you can see from this CT scan, there is a lesion into the body and beginning of the tail of pancreas. And this lesion, it is taking the contrast in large quantity on the arterial face. And this is what we call it arterial enhancement. This lesion usually, when you see a lesion in the pancreas with arterial enhancement, more than the pancreatic tissue itself, this gives you a hint that this is most likely a neuroendocrine tumor. A neuroendocrine tumor, most of the time they are present as solid tumor, not cystic, but here and in many cases you can see them mixed, solid and cystic, like you see in this lesion, because you have the center of the tumor get necrotic and become fluid, and that's why you have mixture of cystic and solid tumor. Of course, the pancreatic neuroendocrine tumors, they are a range of tumors which is start from benign and goes to those who aggressively metastasize to the liver. And their outcome is definitely much better than pancreatic ductal adenocarcinoma, but it could be quite a malignant tumor. All the lesions we said before, they are lesion. They are less common than the lesion we are looking at now. Nowadays, most of the cases we are seeing in reality, they are cystic lesions, and these cystic lesions we call them the IPMN, which is intraductal papillary mucin secreting neoplasia. This term or this disease is actually relatively new disease. I think its first time is described in 1982. There was a few patients with malignant transformation after IPMN. They had good outcome, good prognosis, and the people, they start thinking, well, this is a disease we didn't know about it before. And the reason is because before that time, before the 80s, people with abdominal pain is unlikely to have CT scan or unlikely to have MRI. And for that reason, people, they have this problem, but they don't know about it. So this cystic lesion is a lesion which related to the pancreatic duct, and it is best characterized by MRI, MRCP. And we see there is 3 types of them. The type which is labeled type A in this image. This is what we call it side branch IPMN. And you can see here very clearly that there is a cystic lesion in the head of pancreas, and you see the pancreatic duct. I don't know whether you can recognize the pancreatic duct or not. Pancreatic duct is absolutely looks normal and beautiful, normal size. If you look to the image which is labeled image B, here you can see the pancreatic duct has segmental dilatation, mainly the pancreatic duct in the neck of the pancreas. There is segmental dilatation, and this is what we call it main duct IPMN, which means main duct intraductal papillary mucin secreting neoplasia. And in type C, you can see both of them. You can see there is side branch, which is cystic lesion attached to the main pancreatic duct, but you have also dilatation of the pancreatic duct itself. Now, these lesions are quite common, and the autopsy studies from India and other countries, and then recently they start looking into the MRI, which has been abdominal MRI, which has been performed for other reasons, not pancreatic lesion, for example, for abdominal pain or for Crohn's disease or etc., any other disease. And they found that actually the incidence of picking up a cystic lesion in the pancreas is about 2 to 13%. So if you believe the 13%, that means it is 1 in 8 people, they will have this lesion. It is a quite huge number if you think about it. However, this let's say this difference into the percentage from 2% up to 13% is due to the fact that the studies took different age group. So recently they figured out that the cystic lesion in the pancreas become more common with the age, and there is a publication which is include more than 3,000 patients. When they did the study, it showed that those above age of 70, actually 40% of them, they have some sort of cystic lesion in the pancreas. However, most of these cystic lesions in the pancreas, they are small in size, and only about 1% they have cystic lesion more than 2 centimeters. The bottom line is, nowadays we do imaging of the abdomen a lot, and we expect at least to pick up between 2 to 13% of the patients who have image for any reason, they have cystic lesion in the pancreas. For this reason, it's very important to understand how we can treat this patient, what to tell this patient. Of course, in the 80s and beginning of the 90s, anyone has cystic lesion in the pancreas, nearly they went under surgery and they had resection. And then they realized, hang on, these lesions are most of it is benign thing, and they are not malignant. So then they start to think about it, about how to characterize which lesion has more potential to develop malignancy. So if we look to these 3 images in front of us, we can see that A, it is the side branch IPMN, and these B and C, which is main duct IPMN or mixed type IPMN. The A is the low risk. So side branch IPMN is the low risk. B and C are the high risk. So to remember it very easily, you say, okay, if the cystic lesion in the pancreas is an IPMN, if it is not associated with main duct dilatation, okay, like in A, there is no main duct dilatation. If there is no nodule, if there is no nodule into the wall of the cyst, if there is no septum in the wall of the cyst, if the patient CA 19.9 is normal, and if it is pure incidental, patient didn't have pancreatitis, didn't have any sign of exocrine pancreatic deficiency, then you don't need to worry about that, because this is unlikely to be malignant. However, if you have one of the four things we said, like in B, for example, you have mean duct dilatation, or there is an enhancing or non-enhancing nodule into the wall of the cyst, or the cyst is more than 3 centimeters, or the cyst causing symptoms like the patient have 2 or 3 pancreatitis before, then this is likely to change to malignancy, or probably already has malignant transformation. So this will help us to decide which patient we are going to offer them surgery and which patient we are going to follow up them. So it's very important to understand the difference into the IPMN. So now we just got a quick idea about what is the lesions, roughly the most common lesion which we could face when we do imaging of the abdomen, which lesion we could see in the pancreas, which present as cystic lesion. These are not solid lesions, these are all cystic lesions. Solid lesion in the pancreas could be pancreatic ductal adenocarcinoma, could be neuroendocrine tumor, or could be metastatic tumor like renal cell carcinoma, which going to the pancreas. So solid tumor in the pancreas always need sampling, need endoscopic ultrasound and fine needle aspiration. That's a rule in solid lesion. But cystic lesion not always need that. If we get a diagnosis by radiology, probably we don't need to do that. Okay. Now I'm just going to go through this image to show the malignant development of cancer in the presence of IPMN. So in this image, which is axial CT, you can see there is pancreas, and in the pancreas, you see there is cystic lesion, which is has been labeled by the long arrow, the white arrow, complete arrow. These are the side branch IPMN. However, you can see some dilatation of the main pancreatic duct in the middle of the body of pancreas. As you are going towards the neck of pancreas, which is by the triangle, which is the head of, which is the arrowhead, the white arrowhead, you can see there is a hypodense lesion into the neck of the pancreas, and this is cancer, which is basically it is IPMN, which is mixed type and developed or underwent transformation, malignant transformation, and developed adenocarcinoma of the pancreas. So in this image, we can see there is mixed type IPMN with malignant transformation, which is labeled by the arrowhead, white arrowhead. Let us now just go briefly, very briefly, about the latest American guidelines about how to manage pancreatic cyst. Now, we are not going to talk about, so we understood that if it is, if we go very quickly back there, if it is serous cyst adenoma, an elderly lady, doesn't cause symptom, doesn't need resection, okay? If it is MCN, mucin secrete cystic neoplasm, this usually in middle-aged lady, this need resection because this is pre-malignant, okay? And we said if it is solid pseudopapillary tumor, which is usually happening in ladies in their 20s, yes, it needs resection because it has malignant transformation, and even there is malignancy, their outcome is really very good. Then if we have neuroendocrine, then we have to go to the neuroendocrine tumor board because this patient may need resection, if there is, especially if there is no metastasis. But when we come to this, which is the IPMN, then we are going to follow protocol, which is divide them to two groups, the high risk and the low risk, and how we're going to follow up them, or we're going to offer them resection. So this is mainly what the clinical guidelines is going to take in consideration. So this is the summary of what is the recommendation of the guidelines. And there is something very easy about the guidelines. This is the guidelines, and the last phrase in every recommendation is the strength or the quality of the evidence behind this recommendation. And you don't need to worry about it a lot, because all the quality of evidence behind this recommendation is really very low. The bottom line, you have a lot of experts in the world talking about how to manage the IPMN, but the honest reality, we have no clue what is the best treatment for it, because it's a new disease and we do not have enough evidence to form an evidence-based treatment for it. So even any guidelines you read, always when they put the level of the quality of the evidence, it is really very low quality of evidence. Okay, and this is just because the nature of the disease, because nature of the disease is it is a new disease and we don't know a lot about it. So first of all, if the patient has, so this is the first recommendation they put, it is in the how to diagnose the pancreatic cyst. So these three recommendation is about diagnosing the cyst, is not about how to manage it or to follow it up. So in the diagnosis, be very careful to attribute the patient symptom to the cyst. Most of the pancreatic cysts, especially the small one, which has no dilatation of the main pancreatic duct, they're usually asymptomatic. So if the patient comes with vague abdominal pain and we did a scan and we found the cyst in the pancreas, probably we are missing something else. Probably this patient needs upper GI endoscopy or colonoscopy, because the symptom is not due to the pancreatic cyst. So most of the time, the pancreatic cyst is red herring. We need to follow it up, we need to manage the cyst, but it is not the cause of the patient symptoms. So most of these cysts are just incidental asymptomatic cysts. So it's very important we don't miss something else going on in the abdomen. The second thing, if we're going to follow up these cysts, it's better we follow up them by MRI and MRCP, because MRI and MRCP are non-invasive, doesn't expose the patient to radiation, and in reality, MRCP even doesn't need IV contrast. So you can do MRCP to the patient without any contrast, and that should be enough to tell us what's going on. However, here we need to be very, very careful, which is it's written in the recommendation number 3, that they reckon that the accuracy of the MRI, MRCP in differentiating whether this is a malignant or benign is only between 50 to 76. So between half and 3/4 of the cases. So if MRI, MRCP reassured us, look, everything looks beautiful, there is no worrying feature in this lesion, that doesn't mean definitely the lesion is benign, not malignant, because the accuracy of differentiating between benign and malignant is up to 76% only. So it will get it wrong 1 in 4 cases. And this is very important when you speak to the patient, because if you tell the patient your MRCP is good, then definitely this is benign, and then actually it is not benign, it is malignant. So this is very important. Now, any concern you have, and we will come. Actually, let us come to it now. And this, sorry, this is the high risk characteristic. So high risk characteristic, if there is cystic lesion in the pancreas, and this cystic lesion causes symptoms like acute pancreatitis, like pressure causing jaundice, or the patient has an elevated CA 19.9 in the blood, not in the cyst, in the blood. These 3 criteria make you worry that this is a high risk of developing of being malignant lesion. And then if there is other finding in radiology, we said that before, we said there is nodule, or there is dilatation of main pancreatic duct, or there is increase in the size of the cyst. So if the cyst we did image last year and this year when we did image, there is a 3 millimeter increase in the size of the cyst, or the cyst itself is more than 3 centimeter, or there is a septum in the cyst, So all these things make you worry that this is a risky cyst, and then you go to the next step, and the next step will be you're going to do endoscopic ultrasound and fine needle aspiration of the content of the cyst. So any cyst you are not sure or worry about it, or it meet one of these following criteria, don't just say, okay, we did MRCP, things looks okay, we don't need to worry about it. No, we have to go then the next investigation, which is actually the US and fine needle aspiration. Now, if we get a cyst, and what we going to do with the cyst? First of all, we need to do the imaging, do the EUS to be sure this is an IPMN and this is not a pseudocyst or other lesions which we described before, like MCN, serous cyst adenoma, or solid pseudopapillary tumor which need resection. So if we is most likely this is an IPMN, not other lesions, then we have to decide, is it main duct? Does it have high risk criteria or not? If it doesn't have high risk criteria, we're going to follow up the cyst. We are not going to resect the cyst. But if it is contain any, or it has any characteristic which is, we call it worrisome characteristic, which is high risk criteria, then we may offer the patient resection. So first thing we need to decide, is this patient fit for resection or not? Because there is no point you do endoscopic ultrasound to a patient who is bedridden, who is not fit to have pancreatic resection, just to say, by the way, you have main duct IPMN, probably with malignant transformation, but we are not going to do anything. So if the patient is not fit, and we found there is cystic lesion in the pancreas, then this patient doesn't need any follow-up. Unless they have malignancy of the pancreas, then you have to decide whether they're going to be fit to have chemotherapy or something else, which is very unlikely. Because if he is bedridden, then his performance status is going to be really poor, and he's not going to be candidate even for palliative chemotherapy. So the bottom line is, before you go through the follow-up or resection, you need to ask yourself a question, is the patient fit enough to receive the treatment or not? Because if he's not fit enough to receive the treatment, why we are doing invasive procedure like endoscopic ultrasound to obtain diagnosis? That is not in the patient best interest. When we do the fine needle aspiration, when we do endoscopic ultrasound for cystic lesion in the pancreas, and they do aspiration, the most important, honestly, the most important feature is to decide, is this contain serous fluid or contain mucus? And that is something the endoscopist, the gastroenterologist can tell you. When he put the needle into the cyst and aspirate, if it's easily aspirated and it's a brownish color, then this is serous fluid. This could be pseudocyst, could be serous cyst adenoma. But if he stick the needle and he struggle to aspirate this very thick fluid, then this contains mucus. And when it contains mucus, then it is a tumor. Doesn't say it is cancer, but it is tumor. It could be the MCN, mucin secreting cystic neoplasia, could be IPMN, which is intraductal papillary mucin secreting neoplasia, or it could be it could be, what else could be mucus? I think these two mainly. You have either this or this, and both of them, they need further management. MCN need resection. IPMN either need resection if it is high risk, which is main duct IPMN or mixed type, or it needs follow-up if it is side branch IPMN. Then the gastroenterologist, when he take the sample he sent the sample to the lab, and they will check the amylase in the sample. They check the CEA in the sample, and they send the sample for cytology, looking for looking for malignant cell or high-grade dysplasia. So these are three things which is important. The CEA level, again, it doesn't tell you whether this is cancer or benign, but it tells you whether this is a tumor, whether it is benign or malignant, or it is not non-tumor. So if the CEA is high into the fluid of the cystic lesion, then this is a tumor. Could be MCN or could be IPMN. But if it is low CEA and high amylase, this is more likely to be pseudocyst, because it's completely different treatment. Because if it is MCN or IPMN, it may need resection. However, pseudocyst may not need anything, and if cause of pressure, it may need only drainage inside the stomach, can be done endoscopically or can be done laparoscopically. So it is very important to understand what is the result of the fluid analysis which is obtained from the EUS fine needle aspiration. Then we come to which lesion we are going to resect in reality for patients who have IPMN. Those who have mixed or main duct IPMN, or those who have high-grade dysplasia or malignant cells on fine needle aspiration. These patients, they will need resection. And resection, of course, it depends on the site of the lesion. If it is in the tail of body, they will have distal pancreatectomy. If it is in the head, then they need Whipple's. And some patients, they need total pancreatectomy because the main duct is involved from the head down to the tail. So these patients, they will have total pancreatectomy. Even if there is malignant transformation into the IPMN, the outcomes, they guess it is much better than the ductal adenocarcinoma. One thing we need to understand, or one thing we need to tell the patient when we say to them, okay, you have side branch IPMN, which is this one, and which is A, and this is low risk for malignancy, and you have main duct IPMN, and this is a high risk for malignancy. The patient may ask and say, okay, what do you mean low risk for malignancy? Is it zero? Actually, it is not zero, but they reckon that the risk of malignancy at 1 year inside the branch IPMN, like in picture A, it's about 2 in 10,000. So 2 out of 10,000 people who have side branch IPMN, within the first year of diagnosis, they may develop malignancy. This compared to more than 3% in patients with main duct IPMN or mixed type IPMN. So those with mixed type, we offer them resection. Those with side branch, we offer them surveillance. And this is the statistics. In 5 years, it is, of course, it is much higher. The mixed type or main duct IPMN, it's approached more than 10% malignancy. So this is just statistics, but there are papers which show that actually if you resect the main duct IPMN, up to 60% they may have either high-grade dysplasia or malignancy. So this is the guidelines, and if you come to the follow-up, which is how we're going to follow up a side branch IPMN, again, there is poor level of evidence, and many hospitals, they have different approach. Basically, it is usually you follow up them by MRI, MRCP, if the patient can have that, and either you do it on yearly basis. recently they start to modify the annual imaging according to the size of the cyst. If the cyst is less than 1 centimeter, then you do imaging once every 2 years. If the cyst is between 2 to 3 centimeter, you do it every 6 months. Between 1 to 2 centimeter, you do the imaging every year. And probably if you image someone for 4 to 5 years and there is no change in the cystic lesion, probably you should stop imaging. So you stop the surveillance if the patient become unfit, or if you followed up the patient for 5 years and there is no change, then you stop that. I hope that gives you some idea how to manage the cystic lesion. I'm very and thank you very much for listening to me.
Thank you very much, Mr. Amer, for this very nice presentation. And it is a time for discussion. Anyone have any queries or any question or any comment, please unmute yourself and ask question. Mr. Tamir, you are welcome.
طيب السلام عليكم. Actually, this very hot topics actually in the exams and in the daily practice. Pancreatic lesions are very commonly one of the questions actually you may face in the exam. I want to speak actually about the EUS, and it's became one of the very valuable investigation that in the daily practice. And I don't know if it goes actually in Sudan or not, but currently actually as an example in our institute, doing once it's indicated, doing an aspiration, sending it for a cytology and the part for the chemistry as mentioned by Dr. Amer, in the form of assessing three most important things: is the presence of mucin positive or negative, the other thing the level of the amylase within the cyst aspirate, and finally the level of the CA. It's okay, it just shows it's tumorous or not, and if it's more than 150, then it have some value actually indicating this higher possibility of malignancy, a malignant cyst more than to be a benign. So this is the most important thing. There is definitely different windows actually to the pancreas through the stomach and the duodenum. For example, in the tail, you goes mostly through the greater curvature and of the stomach. And the body of the stomach. If it's in the body, you have the greater curvature antrum and prepyloric areas. And finally, for the head, most of the time it goes actually through the first and second part of the duodenum. So the EOS is a gold standard for the treatment once it's indicated. And I have a question, actually, it's a very common question that present in the board exam. If with the incidental pancreatic cyst, having a patient with a blunt abdominal trauma, she's a 48-year-old female, and during the scan you found, for example, 3 centimeter cyst that present actually within the head, and there is a dilatation of the pancreatic duct for more than 1 centimeter. This is very common question. So anybody please from the registrar that could please give me how to approach this patient.
Tamer, can you hear me?
Yes, sir, I'm hearing you. So no problem. Regarding of the approaching of this patient, definitely will go with the CT scan and MRI, and you will also definitely will order for an EUS. Okay, and just will send it once there is a mucin and there is high amylase level and CA level. Just you will go for the resection of this lesion. It's very common actually question. Thank you very much, guys, and it's open for you. If anybody having a question, Mr. Amer and me, we are welcome.
I have a question. If in our situation in Sudan, if we have no available endoscopic ultrasound in patient presenting with solid pancreatic cyst, how we can proceed?
Mr. Amer?
Well, the best thing in this case to do is to depend on the MRCP MRI. And if the patient can have MRCP MRI, if they cannot have MRCP MRI because they have pacemaker, then probably the best thing is to follow up with CT scan. And if we don't have ability to do EUS and get the information from EUS, probably I wouldn't follow up them by 1 year. I will follow up with them much shorter period. So probably do the MRI once every 6 months the first year, and if it is stable after 2 MRI, after the end of the first year of surveillance, then I would go for 1 year. So you have to adjust that according to the facilities you have with you. And the criteria you go for resection, if the lesion is start to increase in size significantly, like for example, 4 or 5 millimeter per year, or if there is an enhancing nodule which wasn't there before, and now you can see it on MRI, then you will go for resection. Or if the main pancreatic duct 6 months ago was normal and now it start to become dilated, or the patient start to have pancreatitis, then yes, you would go for resection, even without EUS. Remember, the EUS availability, even in the West, it didn't appear in the 80s and 90s. It appeared mainly the last 15, 20 years. So many institutions, they had it for the last 20 years. So before that, they were depending mainly on imaging without EUS. But definitely, if you have EUS, you should use EUS. Why? Because the MRI sensitivity to pick up a nodule is much less than EUS. EUS is more accurate in picking up a nodule which is less than 5 millimeter. However, CT scan and MRI can miss 50% of nodules less than 5 millimeter.
Thank you very much.
You're welcome.
Any more question, Mr. Muhammad, Dr. Muhammad? I know that it was very heavy topic, so we bought actually the pancreas and liver at the same time, which is definitely, it's got a lot of time and it's quite heavy. But if you have any question or any further need for the presentation, that I'm happy actually to share it.
Dr. Arwa, I think have question. Dr. Arwa.
Thank you, Dr. Amer, and for the very concise and informative presentation. I actually have 2 questions. My first question, both questions actually regarding the imaging in liver masses. My first question is for the presentation of hydatid cyst in the first stage. You mentioned that type 1, which is an active disease, they usually have an anechoic homogeneous cystic mass, which resembles the simple hepatic cyst. So how can we actually differentiate between those 2 types of cyst in such patient? Will we go for further testing, or will just depend on the clinical evaluation of the patient?
Okay. Tamir, carry on.
Yes, actually, Dr. Arwa, Dr. Arwa, in regarding actually to differentiate between the simple cyst and the first type of the hydatid cyst, there is 2 things which is very importantly. The first thing that it's the hypodensity that present with the simple cyst, it's never goes actually with the same very low house field that present in the cyst in comparison to the hydatid cyst. Hydatid cyst containing the hydatid sands that gives actually some higher house field measures in the relation to the simple cyst. This is the first thing. The other thing, if you goes back actually to the parasitology, we have 3 layers that we know is actually with the hydatid cyst. The first thing is the endocyst, then the germinal layer, and finally the ectocyst that present with the from the adjacent normal liver tissue. So it's giving the double layer pattern, that it will not be only 1 simple layer, it will be 2 layers. So that goes actually with the hydatid cyst. And I think this is a good way actually to differentiate between the 2. The other thing that definitely the laboratory investigation in the form of the ELISA and the hydatid titer, which is very importantly, actually it comes positive in most of these cases. I hope this answer is okay with you.
Yes. In fact, also regarding radiological findings, you mentioned that the triphasic CT scan can be used to differentiate the different types of liver masses according to the behavior of the mass and the uptake of the contrast in the duration in the phase of the scan. So
Yes.
there is an unclear point for me to differentiate between the focal nodular hyperplasia and the hemangiomas. Both of them have a delayed uptake of the contrast, and both of them they have hypodense in the air phase, and they have a delayed effect. Yes.
Okay, so if it goes back actually with the presentation, the focal nodular hyperplasia is almost always homogeneous. Okay, it's homogeneous, having no clear capsule. This is the enhancement in the delayed phase. In the comparison to the hemangioma, that is giving a cotton wall or a centripetal actually enhancement that present in the delayed phase. يعني كيف؟ دي كلها كتلة واحدة لون واحد في الفوق nodular hyperplasia، لكن الهيمانجيوما كل densities comes actually from the periphery. Once you will go to the center, it's almost تمام hypodense. Okay?
Okay.
Clear.
Okay. Thank you so much, Dr.
Mr. Firas, you are welcome. Please unmute yourself, Mr. Firas.
Assalamu alaikum. I think Dr. Soha Taifour is before me. If she can go, please.
Okay. Good evening, everyone. Thank you, Mr. Tamir, for the very informative presentation. I would like to ask you about the part of the presentation about liver lesions. If I had a patient lay open in my OR and I incidentally finding liver lesion, what do you recommend? If do you think I have to take open biopsy from this lesion, or close up the patient and take him or send him for triphasic CT? Thank you so much.
Well, this is a very nice question.
Yeah, it's very nice.
So if the lesion is cystic, or if the lesion is compressible and you think it is hemangioma, or you have concern this could be hepatic cyst, then don't take biopsy. If the cystic lesion, if it is solid lesion, especially if it is a small lesion, yes, you can do excisional biopsy. Especially if it is a favorable place, like for example, it is in segment 4 and it's near the edge, it's very easy to remove it. But if it is solid lesion and you want to take biopsy, yes, take biopsy. And because even if the biopsy came back with some liver tissue, also it is useful. Then there is an issue with the consent, because is your consent cover the biopsy of the liver? Because liver biopsy is not innocent. It could cause bleeding or it cause a problem. So if the consent you take from the patient covers that or not. But definitely if it is cystic lesion or looks like hemangioma, I wouldn't biopsy.
طبعا say this in addition to cirrhotic patients. Finding a mass actually in the cirrhotic liver, just you have to really taking care of actually while you are biopsying it, because it's mostly could bleed and it might be a tumor. Okay, it might be HCC, for example. So just take care actually. We usually don't be liberal by biopsying cases while in open surgery. Unfortunately, I know that there is some much of difference actually in practice between here and Sudan, because most of the time, most of the patients here, they have at least one single radiological investigation before doing any kind of surgery that involving actually including the abdomen. But in Sudan, yeah, this could be very frequent because mostly they are depending on the clinical exam rather than any kind of radiological investigation. So you might face it, but just remember, if it's cystic, not. If it's cirrhotic, take care, and if it's a small, as Mr. Amer mentioned, you can biopsy it.
No,
Thank you
okay,
for this very kind question. Very nice question, Dr. Taifour.
No, thank you. Thank you so much, Mr. Amer and Mr. Tamir. Thank you so much.
Mr. Firas, you are welcome.
Okay, assalamu alaikum. Thank you very much, Mr. Amer, Mr. Tamir, for both presentations. They were very, very informative. My question is to Mr. Amer regarding the IPMN and the pancreatic tail, if it is turned to be a malignant. So when you operate, when you do distal pancreatectomy, when would you consider splenectomy during this procedure? That is the question. Thank you.
So if you're going to do, so this is unanswered and there is no clear consensus. So it's all depend on lymph node clearance. So if you're going to have, especially if you have IPMN and you think there is a malignant transformation, the classic thing to do is to do splenectomy with it, not for the sake of the spleen, it's for sake of the spleen, the lymph node in the splenic hilum, because if you expect there is a malignancy and it metastasizes to the lymph node, you don't want to remove, you don't want to do spleen preserving lymphadenectomy, and then you turn up, you left a positive lymph node behind you. So this is the classical thing. Nowadays, they trying to do lymphadenectomy in the hilum. They clear the hilum of the lymph node to preserve the spleen. To be honest with you, it's all depend on the risk and benefit. So if you have someone with malignancy of the tail of pancreas, the Achilles heel or the problem you have is posterior positive margin. And the second problem you have is whether you're going to do incomplete lymphadenectomy. 70-year-old gentleman who going to lose his spleen, I don't think he's going to lose a lot. That's in my personal opinion. So probably if you want to do radical surgery, you will take the spleen with you because you treating that like ductal adenocarcinoma of the tail of pancreas, and you want to do complete clearance. And there is a paper from Japan which is very clearly demonstrate that if you go posteriorly down to the left renal vein and to the left adrenal gland, then you take it all in a block, then you will have less positive margin. If you're going to stick to the pancreas to preserve the splenic vein and splenic artery, then most likely, and it is cancer, there is high chance you will have positive margin posteriorly. So it is risk and benefit. Do you want to do radical resection versus spleen preserving? And I personally will go for radical resection.
Thank you very much. I appreciate that answer. Thanks.
Thank you.
If no more question, on behalf of Sudanese Surgical Club, we really thank you, both of you, Mr. Amer, Ibrahim, Mr. Tamir, for this very informative presentation, and we hope to see you in next presentation.
Thank you very much.
Thank you.
Good
Thank
night.
you, Dr. Muhammad. But there was a question, actually, last question that I just read it, about the role of ERCB with the pancreatic cyst. It's about the rule of the ERCB with the pancreatic cyst. Okay, so actually, if you are going with the EUS itself, it's ERCB guided. Okay, it's ERCB guided. Definitely, you to access the pancreas from anywhere, you might not need the sphincterotomy, but if you need to carry on with any kind of stenting things, you will do the sphincterotomy. But most of the time, all the biopsies will not be with the, you could literally say it's ERCB, but maybe it might be just only ERCB guide. Thank you very much. Okay.
Okay.
Thank you very much, guys.
Okay.
Shukran. It's very nice opportunity. Inshallah, presentation will send it to you.
إن شاء الله. شكرا جزيلا. يعطيك العافية.